Hello, is this thing on?
Do you think they can hear us?
Nah, let's say it again. Hi, and welcome to the Gritty Nurse Podcast, an unfiltered discussion related to health and healthcare. My name is Amie.
And my name is Sara.
And we are your podcast hosts.
If you're listening on Apple Podcasts, Spotify, Google, iHeartRadio, Amazon, or any other podcast listening platform, don't forget to subscribe so you can get updates to when we have our latest episodes. Also, don't forget to rate and review us.
And if you like what you're hearing and you love our advocacy work, don't forget to go to www.grittynurse.com and click on the donate button.
As little as $1 or $2 a month for a total of $12 a year will help us with our monthly podcast costs, such as website hosting, our hosting platform,
audio equipment, and the time and energy it takes us to put out good quality episodes. We thank you and we appreciate you. I am excited for this episode. I think that this is very timely. I can't believe we haven't done an episode sooner, Sara, about working with residents.
I know, it's like pretty much a part of your life as a nurse.
Absolutely. And I really hope that this episode will be lighthearted. We can kind of get into some of the, things that aren't really true and just really kind of, dispel them and maybe even get to an area where we can say, how can we better work with residents that are coming in and, how can we show them love? How can they show us love? Sara, take it away and introduce our guests for today.
We have two fabulous medical residents on the podcast today. So the first one is Alvin. He is a fifth-year emergency medicine resident at McMaster University, where he also completed his medical school. His interests are in health innovation, medical education, and being a regular contributor to nursing potlucks. He believes that tuck-in rounds are a life-changing practice, that there is no such thing as too much coffee, and that there needs to be a better mutual understanding between nurses and residents, especially in academic hospitals. And our second guest is Joanna. She is an emergency medicine resident at McMaster University. She completed her Bachelor of Science, Master's of Science, and medical doctorate degree at University of Toronto. Her subspecialty interests include point-of-care ultrasound, medical education, and interprofessional relationships. She is food and coffee obsessed and will attempt to feed anyone and everyone with her cooking. When possible, she will participate in any sport, and similar to sports, she believes great teamwork is the cornerstone of good medical care. I like you two already. Welcome to the podcast.
Thanks for having us here.
Thanks for having us. Pleasure to be here. And super excited to talk about this, yeah.
Well, the fact that you said food is the way to nurses' hearts. So you guys are already winning. We're already excited. So yeah, just great to have you here.
So I'm going to actually start with a bit of an icebreaker, if you will. So we kind of wanted to know from both of you, and maybe we can start with Alvin, we want to know if you can complete this sentence. So the sentence is, you know a resident is around and on the unit when?
I'm going to say when there is chaos on the nurses' ward.
Oh no.
And I'm going to say that because I think that honestly we have a fabulous relationship, but I think that one of the things, especially as a junior resident, is we don't necessarily really understand all the nursing responsibilities. I think we're often quite kind of focused on what we have to do and the responsibilities that we have. And we don't take into account all the stuff that's going on with your nursing care and stuff like that. So oftentimes when we're on the ward, we're writing orders, we're talking to nurses, and we're kind of trying to focus on the things that we need to complete and we need to accomplish without a real good regard of everything that's going on with your responsibility. So that's my answer.
Mm-hmm. Joanna, do you have any take on what it's like to know when the resident's on the unit?
Oh, I certainly do. I just can't pick among all the ones I have in my mind right now. I'm going to say is when you have to clarify multiple orders for the night. And while you're trying to clarify those things and you're trying to page or call the residents, you hear that pager go off and they're in the unit. You can hear that pager go off
I love
multiple
it.
times.
I was gonna say that's like that's like exactly what I was thinking. And it's kind of funny because when I think about residents too, we like my expectation is like they're the ones that typically are the first ones that are going to answer the call. So we know when we hear that pager buzzing, you guys aren't far away, and we're happy that you guys are there, and we're happy that you're coming. So I'm going to jump into it with another little question here. And then please feel free if you guys have questions to bounce off of us, please bounce them off as well. So, my first question to you guys, is it true that residents work up to 80 hours a week? And if that is true, what is up with that? Where is the work life balance? So maybe you can tell us a little bit about if is that a truth or is that a misnomer? And maybe we'll start actually with Joanna first.
Sadly, it is absolutely the truth.
Oh,
So when we get that call at 4 in the morning or that page to clarify an order or, to reorder a medication that may have fallen off the medical record for the last week that the patient may have been hospitalized, there's a reason why we might be grumpy on the other line. It's because that might be, the 22nd hour that we've been working.
yeah, that's pretty brutal.
But I actually think the best person to answer that question is probably going to be Alvin, because he's got some even more extensive experience with this type of work.
So I think this is actually something that feeds into the difficult relationship that we have with our patient care, but also with our interprofessional colleagues. It's just this lack of understanding of kind of the schedules that we work. So I will say, especially in surgery or internal medicine or in ICU, we are regularly working more than 80 hours a week. We do 26 hours on call. We do the regular 7 a.m. to 6 p.m. And so it's quite regular that we would work over 80 to 90 hours a week, oftentimes working 26 hours in a row or more.
Wow. I mean, like, I just can't even imagine because we complain as nurses when we do our 12 hours, but that is just like twice. Actually, that's more than twice of what we do.
Yeah, that's pretty brutal. And like it was actually I actually kind of like I had a question similar to this, but it was actually because I saw a meme today on Twitter, which it's actually he's a doctor, he's a comedian. But essentially he was saying he's like, "Oh, residents work up to 80 hours a week." And it's this weird expectation that is kind of, just kind of part and parcel of being a resident. But he was also saying kind of like, this isn't exactly healthy. So, what's you guys' take on it? I mean, like maybe I don't want to be putting you in a bad situation, but like I would be grumpy after, 60 hours of working. Like how do you guys manage that?
Yeah, no, I I think it's definitely challenging. I think in some ways we take pride in the number of hours we work. I think that that's something that we're working on changing as a society. And while there is actually some evidence that patient care is not affected by the fact that we work 26 hours call, there are provinces like Quebec where they are actively changing it so that there is no call that's greater than 12 hours. So it's a very challenging topic, definitely. But I think one important aspect to that is actually just mutual understanding. And that probably feeds into a lot of the challenges that we have with our interprofessional colleagues. So I'm going to give you an example. Just maybe 2 years ago, I was working on internal medicine. I'd work a day, of course, only on call, and still on call at like 8 a.m. the next morning. And one of the nurses who, they weren't new to the ward or anything. I think that at least been working 5 years on that ward. They said, "Oh, you're on again this morning." And I had said, "No, I'm still the doc on from yesterday." And they had no idea. Like they had no idea that we worked 26 hours call. And I think that, for example, within the night team for the nursing team, they have the expectation that we are available 24 hours or like whenever they want to call. And absolutely, we are there for them whenever they need. But just having that understanding that this might be our 22nd hour, or 24th hour, or 26th hour may really change the way that we approach, the way that we communicate with each other. And I think that's important.
I love that you brought that up because my favorite thing to say, honestly, the next morning is like, "Oh, how are you today?" Right? When the new nurses start the shift in the morning, and they're like, "Oh, how are you today, Joanna or Dr. Dida?" And they'll be like, "Still haven't showered," and then look at me and kind of like give me a weird look, and I'm like, "Yes, because I was here since yesterday, not because I haven't showered."
And see, like, I could see, like, the double side of that comment, not saying that you'd be saying that in a negative way, but that new nurse who might not have an understanding of, like, what your actual day looked like might have been like, "Oh, why did she answer me like that? Like, what's her problem?" Right? But I totally get it, and I think this is why this conversation is super important. But, like, I think I remember something, and maybe you guys can clarify this up for me if my history or whatever is off, where I think I read something about, like, the history behind, medical residents in these long hours. And it was something like this particular doctor was like on speed or something, or taking some type of drug to actually make him be able to do these long hours. And then it just kind of continued to perpetuate in this way. Is that correct? Or am I
Maybe it's
like
an urban legend.
off mark here?
I have actually also heard about this story. I don't know if this is just like
Okay.
this rumor that's
I'm like, I'm
actually,
hearing nothing. I'm a little worried.
yeah, someone who was like doing speed, who designed the program was like, okay, everyone should be able to do hundreds of hours in a row without sleeping. That's also what I've heard as well. Although that's probably not the best system to rely on in this day and age.
Honestly, it's a great question. And interestingly enough, there's actually been a little bit of research to show that when residents finish a call shift, they are similarly incapacitated, for lack of better words, as if they were to have had a few drinks that night. And so I believe it. It's honestly, it's true. Like we don't function as well as we do at the beginning of a shift versus the end of that 26-hour call shift. I will say though that one of the things that makes it a little bit easier is all the food that is usually available around the
Yeah.
nurse's desk for like the night shift, whether it's junk food or like a great, fiesta or whatever it is. And I'm very grateful that typically I've worked with nurses that love to feed me, so it's perfect.
That's that is the key. Like, I mean, we were in labor and delivery, and it was a feast constantly because parents would be bringing us stuff. We'd get our own goodies, and it was always like I'm sure I put on the good like 15 pounds working in L&D as a nurse, just in terms of the treats and the treats that we got from our docs too. So yeah, I mean, maybe we just to keep you guys not grumpy, we need to feed you more.
And you know what? If you work around the holidays, it's like that's just game over. There is no getting away from the endless barrage of treats, like sweet, salty, deep fried, like everything under the sun is just fair game during the holidays. I just wanted to ask you guys, this is sort of changing the topic a bit though. When we're talking about nurses eating their young, I know this is a very common thread with nurses, but I've also heard that nurses eat their residents. And I wanted to know what your thoughts were on that. What do you think, Alvin?
Yeah, so I mean, I feel like I can be quite frank in this podcast, which is great. You guys, I feel comfortable opening up to you guys already. um, I this is my take on it. I mean, I'm gonna preface this by saying that I understand that this must be a really frustrating experience for you guys because the reality is that most of the time when you work with residents, that means you're working at some sort of academic hospital or some of the academic affiliated hospital. But that also means that every month or every 4 weeks, you might be meeting new residents. Maybe they're residents who are familiar with the specialty, or maybe they're just an off-service resident. And for those who don't know what an off-service resident, those are residents who are not necessarily specialized in, let's say, obstetrics and gynecology, but have to work on the obstetric gynecology ward as part of their specialty training. And so every 4 weeks, you guys are dealing with people who are less knowledgeable
Hmm.
and maybe you don't have a great relationship with or you don't even know. So that must be a super frustrating experience. I do honestly think that, it's a very, very challenging time for us as well. The beginning of a new rotation, one of the biggest fears is like, am I going to get along with those nurses? Are they going to be nice to us? And the sense that we just want to really do well, we want to get along with the whole team, and we want to make everybody happy. And one of the major groups of that, of the part of that experience are the nursing team.
So really, Alvin, what you're trying to say, and you're saying it ever so gently, is nurses do eat their residents. Like we can really be assholes to you guys. And I'm just gonna call it straight. And I've seen it and it's not fair. And I think this is where I want to really kind of talk about how we can better work together, how we can better collaborate, because I do see it happening. And it's so ugly on both sides, right? Like I've seen it where, nurses, the resident comes on and they're like, "Oh, here comes the resident." It's like, okay, they are a doctor. So like, let's show them the ropes. Or if they have a question, like be courteous. But I have seen that really, really negative type of behavior from nurses towards residents. And I can't say that I've seen it vice versa, but I've had some very odd interactions with residents. For example, one of my pet peeves is someone coming in and touching you without actually introducing themselves. So for example, actually just last week I was at a fracture clinic, and it was a Mac resident, and they came in to essentially look at my thumb, and the resident came and he just started touching me and like manipulating my thumb, and I was like, "Who are you? Like, can you tell me who you are?" But I think this is where we can talk about how we can build better relationships and really not have that kind of, we're putting people in situations that make them really uncomfortable, and it's unfair. But Joanna, what's your experience with that? Like what's your take on nurses eating their young, and maybe you can tell us how you think we can collaborate with residents and vice versa.
Yeah, I mean, I think there's definitely a little bit of truth to that, to be perfectly honest with you. But I think it stems from something that we can all work on. And in my opinion, the most of this comes from the fact that we are not really aware of what, like nurses are not as aware of what residents work hours are like or work life is like. And residents are probably not aware of what a day-to-day for nurses is. As much as we say we would like to be involved all the time, it's hard to be involved and to learn about other professionals' day-to-day activities when you're focusing so hard yourself on being a good new doctor, learning as much as possible, maybe impressing your supervisors or whoever you're working with, and just being a good human overall. And so, if we worked a little bit more at understanding each other's jobs and maybe understanding each other's responsibilities, I think we could probably find a little bit more compassion and more empathy towards one another. I wish there was a way that we could walk around with a massive label on our head to say like off service, on service resident and name. But like Alvin alluded to, the rotations moves too fast, and the learners, for lack of better words, change so frequently that it's very hard to do that when we're just constantly, quote unquote, starting a new job every 4 weeks, right?
Mhm, mhm. I kind of understand where you're coming from, Joanna, because I feel like as a nurse, when I worked in a academic hospital, I felt like we just got to know the residents and then they went on to their next rotation. And I think it's not even like it, like you said, it happens so fast. It's not like there's an introduction. And I actually didn't even know what off service versus on service meant until just now. And I think that would actually foster a bit more understanding. I think we just need to be more compassionate and understanding towards each other and kind of, give the other person the benefit of the doubt if it seems like they don't know something, or, like it's just taking them a little bit longer than you would like for them to figure out what's happening.
And the truth of the matter is, a lot of the residents that I've had the pleasure of my colleagues that I work with, I'm not going to say everybody because I think there's bad apples in every profession, every specialty, but a lot of them, if you correct somebody in a nice way and in a polite, professional way, I think that goes a long way as opposed to not bringing something up and letting that resident, for example, continue to make that same mistake for the rest of their block and maybe frustrate even other more nurses or the other way around, right? The same thing could be said for a nurse towards a resident or the other way around.
And I think additionally it's a very challenging situation because obviously nurses have a lot of experience, knowledge, skills in their specific ward or specialty, and we know for a fact that we have so much to learn from you guys. But at the same time, we're put in this position where we are the ones making orders and signing things under our name and our profession, that we want to have the responsibility while kind of making sure that we respect the knowledge that you guys have. And there's that power dynamic that might be a little bit difficult to kind of to deal with.
No, and I agree with that, Alvin. Like I think what you're kind of saying and what I'm envisioning too is kind of like, there and it's not even just about the power imbalance. It's kind of like, yes, you're a learner, but you're a learner in the field of medicine. And the nurse who might be experiencing that, whether it's 5 years, 25 years, they still are in a different, so it's like that respect of, that they've had that experience, they've had that lived experience where they've worked on that unit for how many ever years, but also knowing that, within that profession, that's kind of their wheelhouse too. And I really hate the whole, like, you need to be on the charge nurse's good side, or your whole shift is going to go to hell. Like, I think that's not how it should go either. But I think, like, I'm glad that we're having this conversation. I think it's really important to kind of talk about what are the things that we do differently. What does it look like for a nurse? What does it look like for a resident? Because I feel like even there's things that I didn't know about, and it's kind of like, oh, this brings some perspective to understanding, like, what in a day in the life of what a resident may be. But the next question I kind of have is, you always hear this, and I know, don't get mad at me. Can I please speak to the real doctor? Well, I hope we can bust this myth today. You are a real doctor. So maybe we can kind of unpack that a little bit. So, can we debunk this myth once and for all about the resident? Maybe we'll start with Alvin.
Sure. So I think maybe we'll start by kind of defining what a resident is for all those who are listening that maybe not be working in an academic affiliated hospital. So the the realities of the Canadian medical training system is that you finish your medical degree, and contrary to the previous system where you could essentially just be a general practitioner, while we are doctors, every doctor is expected to specialize in something, whether that's family medicine or emergency medicine or neurology, et cetera, et cetera. And so the moment we graduate from medical school, we are doctors and we're able to prescribe and write our own orders under some level of supervision. So when you are calling a resident, you are calling a doctor. The challenge is, though, like we talked about, is that it may be our first year on that specialty training path, or it may be not even be a specialty that we're actually specializing in, but we're required to rotate through. And so it may take us a little bit more time to sort out the right answer for you or figure out what the best answer is. But when you call us, we are the doctor on call. We just might not be the smartest doctor on call in that immediate moment.
Give yourself the credit that you've done a grueling, 4 years, 3 years, depending on the school that you go to, program. And I mean, like, the fact that you're just like, you might not be the smartest, come on. Like, i I know that, for example, like with my knee surgery, I had residents actually being a part of the surgery, and I know, just looking at the incision, I'm like, that was the resident. Look at the care that was done with this incision. And my incisions are beautiful, and I'm not saying that other physicians who are, past the resident school don't have that finesse, but I feel that sometimes residents really take that extra time to make sure that they're perfecting the skill that they're learning. So give yourself a little bit more credit there.
Thanks.
No, I really wasn't going to add much more other than to say, like, an easy trick sometimes is just to look at the badge. And typically, if you have a resident, it'll say doctor before their name. And if you have a medical student, it will say something else. And that's not to, you know, disqualify anyone's skills by any means, but it's just a way to sometimes distinguish different levels of learners in the institution.
And if I could jump in here, I would say that maybe just in general, there's some confusion between a medical student and a resident, because in academic hospitals, there's just so many groups of people coming through all the time. Like, in addition to medical students, there are nursing students, there are new hires. Like, maybe there's just some confusion there. And also, when I used to work in postpartum, I used to teach prenatal classes, and we would always talk to parents that were coming through, like they would always say, I don't want a resident, I don't want a medical student. And we would say, if you're looking for someone that has skill in inserting an epidural properly, you might actually want to have a resident because they're doing so many every single day. Like they're actually really good at it. And so we kind of tried to spin it that way, where we don't want people to think of residents as someone that's inferior to the attending doctor. Like they're actually doctors as well, like you said. And I think that we really just need to build everyone up, with the type of skills that they have.
And I would just add, especially in these big centers and big cities like Toronto or Hamilton or Queens, where the majority of the hospitals are academic teaching centers, the doctors that you're actually normally interacting with are going to be residents. And like you said, it's not that we are necessarily inferior to staff attending doctors. It's just that we play a different role. And so in most centers, like in Hamilton, overnight, 5 p.m. and later, or over the weekends, essentially the only people who are there within 5 minutes of the hospital are the residents, and they're going to be your primary treating team.
Absolutely. Yeah, I think that's key. Like just introducing yourself and making it clear to everyone who you are, I think is just really, really helpful.
So one way that I've seen it where it has actually led to some good outcomes is using simulation. So in residency, and as far as I'm aware, again, not knowing as much about the other professions sometimes, we run simulations where we run different codes or different clinical scenarios that we may encounter in the real clinical practice. Well, what a lot of programs are doing now is that they're actually incorporating um, nurses from that department. So for us, for example, it's going to be nurses that we actually work with in the emergency department who are coming in and participating in our simulation. And we're getting to interact in this sort of artificial environment, but in a way interacting similar to the way we would in a real clinical scenario. And so that's one way where we're learning more, us as residents, learning more about the ins and out of what it takes to be a nurse in a code, for example, and all the different things that you have to do and all of the challenges and the orders that you have to manage yourself, and how to do that in an efficient way. Well, similarly, doing simulation, I think nurses are seeing us in a different light, where they're now seeing us truly as the learner, and they're seeing the challenge that we're going through, learning how to be a more efficient team leader, learning how to be that doctor, quote unquote, that you call on in the middle of the night. So that's one way that I think I would encourage that both residents and nurses continue to collaborate and try to learn more about each other's.
Okay, good to know. So, I kind of just wanted to talk about, just sort of everything that we've talked about, like how you sort of see we could work better together. Like, I'll give you an example. I used to teach NRP, so neonatal resuscitation program, and we actually ran this program with everybody involved. So we did, everybody would have to take it every 2 years. So it would be RTs, it'd be physicians, it'd be nurses, and they all learned together. And we actually ran codes together with everyone, rotating the different roles. So that's one example I can give of how we can actually work together in a way that makes sense clinically. And I just wondered, like, if you guys have any ideas or even experiences about how nurses and residents can work together better. Maybe Joanne, I'll start with you.
Yeah, I was just going to say, like, one of my best memories is honestly walking into a unit that I don't work very frequently at, but I do work frequently enough that I've actually gotten to know the nurses to the point where they know sort of my limitations and I know their capabilities and all these things. And I walk in and I'm very comfortable being like, you know what, can you show me again how to set up this pacer box? Because honestly, I haven't been here in a couple of weeks and you do this every night. But on the other hand, with that exact same nurse, I can very well be, you know what, I know you always give this medication for this particular reason, but I think in this clinical scenario, we should try this specifically. Even though you do the same thing always with every patient, it's exactly this clinical scenario where we need to use this other medication. And these are the reasons why. And I just feel so comfortable being myself when you have that mutual relationship. This is only, however, possible because I've worked with them before, or I've put in the work to get to know we've both put in the work to get to know each other.
Mm-hmm, mm-hmm. And Alvin, do you have any thoughts on this?
Yeah, I think that it'd be really ideal if we could both take more time to learn about each other in terms of our professions, but also kind of like as a person, and just humans. So I remember oftentimes on call, whenever I had a chance, I would actually sit by the nursing desk for a couple of reasons. One would be just kind of to make sure that like all the orders I needed to sign were signed before I headed to the call room, to make sure that there weren't any other questions or anything I needed to do. And those tuck-in rounds that we talk about, are again really game changing because it gives you a chance to chat with all the nurses and their concerns and their issues before you head off, so that you don't actually get those calls at 4 a.m. about those things that you probably could have dealt with earlier on when you were actually awake. But that also gives a chance for both the nurses to kind of like get to know you as a person, get to know what your night is like, get to know kind of the challenges that you've had that night on call, and for you to understand nurses as well. So like when I sit by the nursing station, I hear all those call bells ringing nonstop, like the uh, crazy number of orders that they still have to deal with at daytime that didn't get done during the day. And I think getting to know each other's challenges will really help build those relationships that are important to making sure that our patients get the right care.
Yeah, Alvin, like I mean, that is actually one of my best experiences that I've had with a resident. So I remember actually I was actually training to be a labor and delivery nurse, and there was this one resident and he was just like the life of the party. It was actually when I was at a hospital in Brampton, and he came in and he chatted all the nurses up, and he's like, hey, why don't you show me this, and just that interaction and just sitting around just to kind of learn the lay of the land. And I know it's probably nurses can be super intimidating and scary, but I think that is definitely the way to start building relationships so we can see each other more. Because I've also had the opposite where you know um you only see the resident when they're being called, and you're just kind of like, well, who is this person? And then that trust isn't there, right? You just don't feel that sense of trust because you don't know what their ability is unless they're called into a situation. So I agree. Like, I think that nurses, one, we need to be a little bit more receptive to saying, hey, we have learners here and they're learning in this field, and we need to kind of not even, I was gonna say, give them a wide berth. That's like my labor and delivery head. But just to say, hey, they're learning here, we want to support them, and how best can we help with your learning journey and not seem like these scary scary people. And then just also, I think that presence, like you said, Alvin, coming in, sitting down, bringing your food, I'm telling you, we're already bought. You bring some Tim's, we're bought. You've already won your way into our hearts, right? So I just think that collegiality is hugely important. And then I agree too with you what you said, Joanna, that interprofessional stimulation. So I actually did a lot of work with, I don't know if you've met her or have heard of her, Dr. Saru Sharda, at one of the organizations we worked, and she did a lot of work on simulation. So that is a huge and really important part into seeing what each other does, right? Understanding what it looks like on that other end, on that other person's end, and then saying how can we best kind of move forward if we ever had the situation again. So again, two huge, really important points. Sarah, do you have anything that you'd like to add?
Yeah, I was just thinking as you were talking, it's one of the things that we talk a lot about is the importance of debriefing. So if there's ever been a code or a really sort of stressful situation, I think it's really great to debrief as a team about, what went well, what could have gone a bit better, how did you feel, and I think it's just important to understand what people's roles are because, there might be this expectation that, the resident was supposed to do this or the nurse was supposed to do this. But if we actually talk about it, maybe there's just a lack of clarity in general. And debriefing is so important, I think, for your mental health and just for growing as a team that I think this is something that nurses and residents could do better at and do more consistently. So that's just one little thing I wanted to add.
Yeah, I agree
And
with that.
if if I could just yeah, if I could just build on that, I think another thing is that just the recognition that There's always something to be learned from each other. So I can count like countless times. Sorry, there are countless times where I've been managing patients and I've asked for nurse for help, and I've literally just stayed and asked, "Hey, could you show me this? Could you show me how to do this? What's important to look for? How do I put in this Foley? What are the tricks and stuff like that?" And I really, really also appreciate it when a nurse asks me in a very like, thoughtful way, why was this ordered, or like, why did you guys do this? Because I think that there's a lot of stuff that we can learn from each other's professions that will actually make us better practitioners. And once we recognize that, I think that our relationships will actually, go to the next level.
Mm-hmm.
Yeah, I agree.
I think everything that you guys are alluding to, it just reminds me, it brings me back to the importance of psychological safety, like feeling comfortable to offer suggestions or ask questions about why things are a certain way. And I think you can only really do that by spending the time with people, getting to know them, like you said, Alvin. It's just something that we need to work on. And I think that when you have it, it just makes the team work so much better together.
Like I'm glad that we've kind of captured all these points, and I think actually if we boil this episode down to just one word, it's communication. Right? It's
Absolutely
just
agree.
like we just need to be better communicators, and I know it's such a different, like everything's so fast paced. We're moving, we're trying to make sure that we're getting those orders in, or we're executing those orders. But if we take the time to communicate with one another, I think we'll have a better understanding of what that resident's going through, what that nurse is going through. And again, it boils down to communication. But I'm a little bit nervous now. I don't know about you, Sarah, but Joanna and Alvin, do you have any burning questions for myself and Sarah?
So this is our shot now. I see what you're saying. Well,
I'm super nervous. I'm sweating a
oh,
little bit.
that's how I feel every time I go into work. I'm just kidding. No, absolutely not. Actually, you know what? I do have one question. How do you feel about
All right.
sharing your break room? It's this interesting phenomena where depending where I'm working at, sometimes it really
I'm sorry, I'm
no, that's
laughing.
okay. That's a good sign, I think. Everywhere I work, I just like the idea of going into the nurses' break room because to me is I get a chance to sit down and chat with the nurses and maybe get to know them better, especially if I don't know them from before. But sometimes I feel like I get a bit of an evil eye. Sometimes I feel like, maybe this is not the best spot for me to be.
All right, maybe I'll give you my take and then Sarah,
Hmm.
you jump in. So I think the nursing break room is the place where you learn the most about nurses, honestly, like cuz we can't put it all out there while we're on the units or while we're in even in just like, in the nursing station, but I feel like the break room, that's where you really get to see kind of like the personalities, that's where they come out. And so I've had both experiences. I've had the experience of sharing a break room, and it was actually really cool to sit down and eat lunch with a resident or a doc, and you get to learn a little bit more about them from a personal standpoint. So I personally think that it's a good thing, but I have seen situations where the evil eye is given, and I'm kind of like, like really, they're not coming in here and asking you about an order. Like I think this is where we all have to agree that the break room is not to talk about anything medical. Like we just don't bring it in there. We don't want to talk about it. But I think it's a good opportunity, a good place to build relationships as well. So unfortunately, I have seen the evil eye being given, but I think
Hmm.
even myself and Sarah, we both worked in a place where we did have physicians and residents come and eat with us, and I thought it was great.
I'm just like picturing every single break room everywhere I've ever worked, and I have to say, it like at least in my experience, it wasn't a common scenario to have residents or doctors share the break room, and I think it's a good practice. Like if you make it a regular part of your routine, I think people initially they may have their guard up because they're wondering why you're there,
True,
but I
true.
think eventually, as you get to know people, they'll kind of warm up to you, and I guess like if you've never gone into a nurse's break room before, it's probably good to just like let people know that you're just there to eat lunch and that you're not there to like, I don't know, you don't have another agenda in your head because nurses can be kind of territorial about their break room. Like one thing I learned early on as a nurse is that on nights you never ever ever use the break room to eat, to heat up
Yes.
food. Like I did that once by accident and I'm telling you, Like, the amount of gossip that went on behind my back, it was unreal. Of course, nobody said anything to my face, but I got it really hard afterwards. So I think it's just getting to know what the cultural norms are of the unit and just kind of putting yourself in there, and you will get to learn a lot about nurses. And, I think that's the best place to bond with them, actually,
Yeah, I
over
agree. I
food.
think, and I think,
Like I said, food obsessed.
right? And I think this is where this is like, I think that would be actually a good practice, because, there is that I don't even want to say imaginary, but there's that imaginary demarcation, right? Where it's just like, well, this is where physicians go, and this, like, the physicians have their call room, the physicians have like their dictating room, the physicians have like their special spaces, and even nurses are kind of like, I don't want to like mess with that. But I think that, maybe we do need to have spaces that are more common. I believe actually at the hospital again that Sarah and I were, the change room was not just for physicians and nurses. There were physician special lockers, but it was a change room for all of the staff that were on that unit. So there was like the female change room, and then there was the male change room. But I think this is where, I'd say that, yeah, we need to create spaces where it's safe for us to have these conversations, to build up our relationship. So I think it's a win-win. I think nurses need to not give people stink eye, but maybe learn a little bit of the ropes in terms of some of the do's and don'ts in the nursing station. I mean, sorry, in the break room.
And maybe I'll just add, if you guys didn't know, oftentimes the doctor's room are not actually privy for residents. So there's like
Oh
the
my
staff
goodness, I
room,
didn't know that.
and there's the
Oh
nursing room, and we're
no.
just kind of like this floater that's not allowed to access either. Yeah, yeah. So we're like seeking a bit of salvation
Oh no, I feel so bad.
and peace and quiet and acceptance in the nursing break
Oh
room
my
because we're not
god.
allowed in either.
Oh my goodness, I had no idea. There should be like a residence they you're kinda stuck in between, like, you don't really have a home.
Well, that makes sense. That's probably why, for example, I used to see residents in the library sometimes, or they'd be eating in the cafeteria because, maybe they don't feel welcome in the nurse's break room, or, they're not really privy to the doctor's room. You know what? That sucks. You guys come and hang out with us anytime. You nurses out there listening, let the residents eat with you. If you see them, you say, hey, you have a place to eat, you have a place to put your bags, come over here.
I mean, I'm happy to offer food, honestly, like I
That is
said. I'm telling you, just be so well fed all the time.
I think I would really like working with you, Joanna. I would be so looking forward to whatever you have to bring.
Any other questions for us?
Yeah, I'm gonna maybe ask a little bit of a more challenging question and maybe more of a touchy subject. So I don't think that I've experienced this as much, but I think it is not uncommon for my female colleague residents to have oftentimes a more challenging time with nurses, whether it's with orders or just their interactions with nurses. Maybe feeling a little bit more like the nurses think they're bossy or stuff like that. And do you guys have any insight as to why that is, or do you have any comments on what the accusations I've just made?
Oh, I'm happy to start. So, you know what? I think being in a female dominated profession is really tricky. So I think when it comes to nursing, we're 90 and 91% female. Um and there's a lot of disempowerment in nursing. So I don't know if you guys have ever listened to our podcast or listened to us talk about kind of, the history behind nursing, and kind of where this might come from. And I really hate when people say it's just about us being women, but there is a lot of disempowerment, and I think there's also a lot of disempowerment through the hierarchy in medicine as well. And I don't want to speak for other people, so really, nurses, don't come for me today, but I'm gonna kind of give my take. And I think that there might be, I don't want to, I'm so worried about using the word. I think there might be a little, I don't want to say jealousy. That's not the right word. I feel like there's a little bit of they feel I'd say that they feel the power imbalance, and then they feel it more because it's another female colleague. And I don't think it's like, I mean, I'd say by no reason, or no, there's no right to give another colleague a harder time. but it does beg to question why that interaction might have happened or occurred. And again, I think I'd want to say, hey, like, can we talk about what that interaction actually looked like, to say, whether it's something nursing specific or whether it is something, specific between a female who might be in power over another female. I mean, in terms of the hierarchy. But I mean, that's a really tricky question. And I think that for me, that would be a give me more information in terms of what did those interactions actually look like, because I think just sometimes females can be really catty with one another and do the bitchy talking, and I don't really have time for that. Sarah, what do you think?
Mhm. You know what? I'm gonna say that I think there's a little bit of a double standard because, and I know traditionally, yes, women have been nurses, and traditionally there have been more male doctors than female doctors. So I feel like nurses kind of know how to act when it's a male doctor, but when it's a female doctor, they feel like if there's a conflict, they would probably, I'm just going to make a generalization, they would address it in a different way than they would with a male doctor. And what I mean by that is the cattiness, the talking behind their back. Maybe there's been gossiping. I just feel like this is the way that a lot of nurses operate. Not to say that it's right, but I think that may be where the difficulty with female residents comes in, is that there is sort of a power imbalance, and it maybe the nurse doesn't know how to handle it, and she just deals with conflict in a really ineffective way.
If I'm thinking about some interactions I've seen too, there's there like you said, there is that double standard. And I guess I've seen where the situation is on, like, let's say a female nurse challenges a male physician, that interaction happens quite differently too. And that not all the time, because I don't want to say it always happens that way, but I think because there's a lot of things happening there. So there's the hierarchical structure of the male being a physician. Then there's also the sexual aspects, so being a male, and those type of power imbalances. So I think there's so much more in that particular situation, where I've seen even very, I guess I would say, quote unquote strong nurses back down from, maybe a situation where they might actually be making a correct judgment, but that interaction between the male physician and the female nurse is not really a positive one. And then I've seen the situation on the other foot where, female to female, it's just like they feel that they have more authority to challenge, because that female doctor won't push back in such a negative way as, that male physician might be. There's so many different dynamics there to kind of unpack, because, like, we can get into, gender discrimination, we can get into a whole bunch of other things. But I mean, I think there's a lot there to say, in terms of what actually might be happening in that interaction. It's more than it just being a nurse and a female nurse and a female resident or female physician. Jeez, you guys with the hard questions. Well, you know what? I'm gonna bounce this back. I'm gonna bounce this back to Joanna. Like, what do you think? Have you experienced something like that as well? What do you think it might be?
I don't quite know what the answer to it is, because I think if I knew it, I'd have a solution then for this problem that probably has been going on for a long time. But I certainly discussed with other colleagues that, and I think it is a real issue, to be perfectly honest with you. But like you alluded to so beautifully yourself, it's multifactorial, whether it's, generational, whether it's a power dynamic, whether it's the nature of how we deal with conflict as a female versus a male.
Hmm.
And, there could be many, many different reasons. And it definitely needs to be unpacked further. But a great starting point will be to just talk openly about it, almost that debrief. If you see that there's a conflict, maybe the best thing to do is to just talk about it right there and then, and clear the space and move on, as opposed to continue to build on this conflict and make it an even bigger deal down the road.
Yeah, I think that I always think that, when there's a difference of opinion, especially when it comes to like a difference of medical opinion, I'm always of the you don't have to hash it out in front of the patient. Like, just please pull the person aside, or if you feel that there are those differences, or there's a conversation that you feel that needs to be had, pull the person aside like that. I think that's just the general humanistic thing to do, to say, hey, we might have had this interaction. Can we talk about it a little bit more? Or, hey, this made me feel uncomfortable and this is why. We just need to do a better job of actually, one, dealing with it, and not just letting it fester or whatever, and then just pulling the person aside, say, hey, I'm not too sure if I understood what happened there. Can we talk about it? And it's to be honest, it's actually really not a easy thing. Myself and Sarah say it is something that you almost train yourself to do, because most people I know in terms of females aren't very confrontational. But I think we just need to have the conversation, just to say, hey, this interaction occurred. Can we talk about it and talk about how we can move forward and learn from it?
I was just going to add one thing. It's actually one of the most efficient ways I've seen this done in my limited years of practice thus far as a resident, is to actually sometimes have a third person that might not even have been the person involved in that interaction bring it up. Because just like you said, you have to be cognizant of it, and you have to be very forward, and it is uncomfortable to bring it up. But sometimes it's that third person, whether it's another nurse or another resident or a staff physician or whoever may be in the room, that person sometimes is the best one to bring it up, because then it's just coming from somebody that wasn't even involved, and there's no longer that imbalance.
That's a good strategy. I haven't actually thought of it that way before. As long as that person is neutral, like I think as long as that person doesn't appear to be taking one side over the other, then it would work.
Yes, absolutely. Thanks for clarifying.
Yeah, I agree. Yeah. Any other questions for myself and Sarah?
Yeah. So if there was kind of like one thing that you could have residents take away from this podcast who are listening, what would be the best way to get into the nurses, on the nurses side, when they're starting a new rotation, other than buying a bunch of coffee and donuts, which I do every week on on
Right.
call?
I'd say the first thing is just to introduce yourself. Like, I think sometimes what happens is, the busyness of the unit, you might be only there flying in for a very short period of time. I think you'd be surprised if, on that first shift that you came in, if you came in with the attending or whoever, just to introduce yourself. Hi, I'm Alvin, and I'm the resident that's going to be here for the next 4 weeks. I think that would go like miles. I think you would floor nurses. Nurses would just fall off their chair and be like, "Oh my god, this person's talking to me." I think that introduction is hugely important, and I think that it would be greatly appreciated. What about you, Sarah?
I think that's important as well. And also just, get like we've been saying, getting to know the nurses, and don't be afraid to ask questions, because at least from my perception, what I've seen a lot is residents that come onto the unit, they don't say anything to anyone, they write orders and they leave. And the perception from nurses is that the resident thinks that they're better than everyone. And that may not be true at all, but that's the perception when there isn't very much interaction. So then people are kind of left to make their own assumptions about what that resident's motivation is. So I think it's just good to sort of be approachable and let people know that you have questions or that you want to learn from them and you value their expertise. So that's my my suggestion.
Any other questions?
I think that's it for us for tonight. Maybe for another episode.
All right. Well, thank you so much, Joanna and Alvin, for coming on the Gritty Nurse podcast to talk to us about what it's like to be a resident, what it's like to have an interaction and interactions with nursing staff, and how we can better forge the relationship forward. I think when we talk about interprofessional care, I think all our goals are the same. Our goal at the end of the day is to make sure that we have healthy patients, we see great healthcare outcomes, and that we are serving the people that we dedicate our lives to taking care of. So I mean, I hope that you guys got something out of this conversation. I hope that the listeners have gotten something out of this conversation. And again, thank you guys so much, Mac Emerge residents, for coming on and talking to the Gritty Nurse podcast.
Thanks for having us. This was such an important conversation.
Thanks so much. Yeah. Thanks so much for having us.